Welcome to Healthy Talk, empowering your wellness one conversation at a time. I'm your host, Rachel Mann, and today we're diving into a topic that affects every woman at some point in their life, perimenopause and menopause. Joining me are two of our Boone County Hospital experts in women's health, certified nurse midwife Megan Sloat with Madrid Family Practice, and Dr. Lindsey Hay with Boone County Hospital Family Medicine. Megan, Dr. Hay, thank you both for being here today.
Thank you for having us. We're glad to be here.
Let's start with some introductions. Megan, can you tell us a little bit about what you do at Madrid and at Boone County Hospital and what led you into women's health?
Yes. So as Rachel said, I'm a certified nurse midwife, which means I'm a nurse practitioner specializing in women's health and able to deliver babies. At the clinic in Madrid, I see women from the teen years through menopause, including pregnancy. Then when I'm not in the clinic, I might be at the hospital on labor and delivery, helping with that call schedule. I was drawn to women's health partly after a year I spent in Namibia, Africa. And during that time, I met a mom who had HIV and her child who did not. And I became really interested in mom-baby work and taking care of that dyad, particularly in that setting and focusing on public health. And then when I got back to the States, that all translated into what I studied and what I focused on and how I could do that here.
That's great. Dr. Hay, what about you?
Well, I just want to start with saying we are so happy to have Megan here with us. She's been a fantastic part of our team in making sure we continue to have really good access to women's health out in Madrid. I'm over at the North Clinic. I've been a physician since 2011 and chose family medicine because I liked the entire breadth of just our experience, this journey, including newborns, delivering those newborns, men, women, as we age. You know, we're in a spot as family medicine doctors to really help people identify when something is a symptom. And perimenopause and menopause is a different set of symptoms for a lot of people that I think, certified nurse midwives and family medicine physicians, since we see people through such a spectrum of their life experiences, we're in kind of a unique place to really help identify when something has changed and feel like a really safe place to talk about these experiences. Because I think for a long time, women thought they were crazy. And we're finding more and more that it was just an unapproachable topic. People didn't know how to talk about it, if they were talking about the right thing or what the word was for what they were experiencing. And so this has been a lovely time to be a woman and explore this with their people that you really trust.
Yeah. Okay. So you both see women through so many stages of their life, from starting families, caring for aging parents. So why is this particular transition so important to talk about?
I think it's important because our experience has changed compared to when medical textbooks were first being made and it was all very male driven. Now we're noticing that as women are going through this really challenging, what we're calling kind of reverse puberty, we're also at the heights of child rearing. We're also at the height of maybe our careers or starting a new business, or are asked to do lots of different tasks, including maybe caring for aging parents. And we really think that though this is a natural process for most women, unless there's a surgical intervention or a medical intervention that causes you to go through menopause earlier than one would expect, that we are in these incredibly productive phases of our lives and we can help people transition through this process more gracefully and in a way that supports the other aspects of their life that are really important to them and to their families or their careers that maybe wasn't as talked about as much, especially if people were not having jobs outside of the home. It's a transition as women's roles have transitioned. This feels like a natural next phase is to help support women through that process.
I think the other element of the reason it's important to talk about it is because for so long we didn't. And it's so integral into how we're performing in our life at that time that we have to pay attention to it. We have to validate it and we have to listen and hear what women are experiencing. And now I just think in this era, we have a lot more tools to do that and a lot more willingness to have that conversation.
Yeah, I feel like the more you talk about anything, the more people feel like they're not alone going through something alone. So let's start with the basics. Let's define these. What exactly is menopause and how is it different from perimenopause?
So menopause is always a retrospective diagnosis. It means that you have had 12 months without a period and that there's no other reason for that to have happened. So if you've had a hysterectomy and you haven't had a period for 12 months, that does not mean that you've gone through menopause. If you still have your ovaries, you're still producing all those same hormones. So for most people, this is something that happens in our 50s. I think on average, it's 52 years old. It can happen much earlier than that, and it can't happen from surgical or medical procedures. And so we might be able to call somebody in menopause much sooner than 12 months if we know that we have taken away their estrogen from a medical perspective or a surgical perspective. Perimenopause is this kind of nebulous, abstract, can't really diagnose it outside of clinical symptoms that happens in the years before your period stops. For most people, there are symptoms of hot flashes that start even before your period stops. There are joint pains, brain fog, more headaches, sleep disturbances, changes in libido, changes in your skin, changes in your hair that sometimes happen all at once. And for most people, the reason why we use that term reverse puberty is just like when we started having periods, it didn't start instantly. We just went from like being young prepubescent children to suddenly we had breasts and hair and periods, and it was all happening within like a couple days of each other. We eased into it. I can remember my mom being like, must be starting your period. And that was, I think, 3 years of her claiming that it was going to be coming because I had all the mood changes. I had the acne that was coming. It was this process. And the reverse is true. We start having symptoms, some people as early as 10 years before they ever have changes in their period or their period stops. For a lot of people, periods are the first thing that they notice. They notice their periods are getting closer together or further apart. They're becoming heavier or sporadic. And there is an investigation that we do with our loved ones and with our physician or our midwife to try and figure out if the constellation of symptoms could fit with perimenopause. And sometimes it is this diagnosis of exclusion where we rule out everything else.
It sounds like a roller coaster.
It is. It feels like a roller coaster, I think, too.
You've talked about all these symptoms. How do you know that it's perimenopause?
The Menopause Society has said if you have somebody who is having classic symptoms of perimenopause, which would be like hot flashes and changes in your period, and they're over the age of 45 and having classic symptoms of perimenopause, like changes in your period, either more frequent, less frequent, heavier, and hot flashes to go with it, we really don't need any other information to diagnose you with perimenopausal symptoms. Based on your own specific history, you might be someone who we would want to look at your thyroid or look for other causes of hot flashes that we wouldn't want to miss. We would want to do an exam, make sure if there are labs that we want to make sure we're not missing a different diagnosis that could have similar symptoms. So it's not a one size fits all. And some of this includes making sure there's nothing else we're missing to help us make that diagnosis.
So let's talk about what happens behind the scenes. What's going on hormonally that causes all these changes?
Hormonally, we see that the ovaries are no longer producing the same amount of estrogen. And just like puberty, when the ovaries were starting to produce more estrogen slowly over time, it's a slow process for most people where they make less and less. There are changes in every single cell of our body, including our brains, in response to the lowering amounts of estrogen month after month. And our bodies respond to that. And we notice that our FSH levels, which try to get the egg to come out of our ovaries, go way up in an attempt to try and squeeze every last bit of estrogen out of our ovaries. And our estrogen levels decline over time, not completely to zero, but to a level where it isn't functional in the same way that it was in a premenopausal level when we were having regular periods.
The other thing that I think is notable is when those hormones are fluctuating and changing, when that FSH is doing its work and the estrogen is declining, that's when we can get irregular bleeding and unpredictable patterned bleeding that often is very confusing to people, but it's just your body making those hormonal transitions over time.
How much do things like diet and exercise, sleep even, affect how women feel?
That is actually the first place that we start when we talk about perimenopausal symptoms, and actually the biggest bang for our buck in helping cope with these changes. And for a lot of women, it's all that is necessary. We know that all of the symptoms that really bother people, the joint pain, the brain fog, some of the mood changes, troubles with sleep, troubles with libido, troubles with joint pain, and the hot flashes get better with exercise on a regular basis, gets better with having really quality food, whole food, mostly plant-based diet, things that are kind of low from an inflammation standpoint. And the biggest bang that people get for their buck is by stopping smoking if they're currently smoking, because a lot of the symptoms that come from use of a stimulant on a regular basis, like nicotine, mimic the symptoms of perimenopause and menopausal symptoms, which I'd like to say that when your period stopped, all of those symptoms of perimenopause also went away, but they don't. And it's the same problem. I don't know if it'll be 1 year that you'll have those perimenopausal symptoms or 10. And so there is a management component of tolerating and learning how to adjust to the changes that are going on through your body. And lifestyle is a fantastic way of making those adjustments.
I think they're also often so interrelated. So say someone's not sleeping well, then they're going to have a hard time being in a good mood the next day. They're going to have a hard time being motivated to exercise. And it's just sort of a vicious cycle. Yeah. And so if we can correct one of those and really focus on one of those with some number of tools that we have to offer, then by fixing one thing, we can fix many of the things.
Is there one thing that you've seen women complain about more often than other things going through perimenopause?
I would say hot flashes are really disturbing, and that's where we have our biggest set of evidence as far as interventions that we can do with hormone therapy and non-hormonal medications that we can use to help people. And so that's a big area of focus for a lot of people. The harder problem is when somebody comes in with no hot flashes, and they've got this brain fog that they just can't explain, and they are noticing changes in libido, changes in their period, changes in their mood. They're just irritable, and maybe that's affecting sleep somewhat. And it's hard to tell in those circumstances, whose fault is this? Could it all be perimenopausal symptoms, or is it something unrelated? And that's where it gets kind of difficult. But I think part of the reason why we were excited to do a podcast is that there are these other symptoms that sometimes aren't obvious at first that they're perimenopause. And talking to somebody about them, maybe we identify that you're actually incredibly depressed and anxious, and that's the problem. But it begs that question, and making sure we keep perimenopausal symptoms on the list of possibilities for symptoms that you could be having.
Okay, let's talk about treatments, because you talked about hormone therapy. That I feel like used to be pretty controversial. Where do things stand now?
Back when the Women's Health Initiative was first released, there was concerns that came from that estrogen therapy increased risks of stroke and heart attack via blood clots. We now know more information that the way that study was done, it made sense that there were problems for those women. The women on average were much older than we are starting people on hormone replacement therapy. The doses of estrogen treatments that they were given were higher than we currently use. The method of providing those hormones was different. And so unfortunately, it did the right thing. It made sure that we were paying attention, that we didn't just throw hormones at people without being thoughtful about it, and that we do need to ask questions about who are the correct people, the low-risk people that this would be safe for. But unfortunately, it had the effect for a long time there of saying, like, we shouldn't even go down this path of research. We shouldn't even offer it. Nobody should be offered this. And we now have new research that says that in the right circumstances and with the right set of conversations between yourself and your provider about the risks and the benefits, it has opened up treatment and prevention for lots of different illnesses that hormone replacement therapy can help with.
Is it something that can be tailored per individual?
Yes, absolutely. And so there's sort of like an initial starting point, which is that the goal for treatment is that we're starting women on hormone therapy at less than the age of 60 and within 10 years of the onset of their menopause. So that would be more like treating a menopausal person. Then there's this whole realm of treating the perimenopausal. Okay, but that kind of guides when we would start someone. And then in terms of how we treat someone, generally speaking, if someone's having vasomotor symptoms, the number one treatment approach is to give them estrogen. And there are different formulations of how we can do that and different doses. So that's where you can titrate it to the individual. We do know now that treating women with a transdermal estrogen patch is the optimal way to go in terms of reducing risk of blood clots. So you have an oral option, there's a gel, there's a ring, and then there's a patch. And so a great place for most people to consider starting is with some dose of the patch. If a woman does have an intact uterus, then we need to also make sure she's getting some sort of progesterone to protect her uterine lining from building up to what could become potentially cancerous cells. And so when you're given estrogen, you need to then suppress the endometrial lining so that it's not just building. The way we do that is by giving a progesterone. And there are, again, many ways that we can do that. Some of the most common ways that depend on the individual. One way is the Mirena IUD, which is something that we can talk you through the risks and benefits of that choice. The other really common choice is oral progesterone, which would work in conjunction with and opposing the estrogen.
And I think what Megan alluded to is that, no intervention, including doing nothing and being miserable for maybe 20 years of your life, comes without risk. Mm-hmm. And so before we start these medications, this is the conversation that you should be having with your provider, is whether or not you fall into a category of people where the risks are low enough for you that the benefit would be worth it. So for a lot of us, that means doing cancer screenings, making sure that we're not in a high risk category for blood clots. And, before I think Megan or I ever start anybody on this, we figure out what is your concern? What is the biggest problem for you? And she alluded to vasomotor symptoms, which are really the hot flashes. But there are well-known, well-documented other symptoms of perimenopause that are not as well studied. So is it possible that your brain fog and your joint pain and your skin and hair changes would get better with estrogen? It's possible. It's a really hard thing to study. And we don't have great studies that show us that it gets better. So it's something that we definitely, before we start anything, make sure that we understand what your risks are and then what we're hoping to achieve with the medications. Because the nice thing is that there are great research papers out there talking about non-hormonal options for treatment. There are different medications that we have classically used for depression and anxiety or even neuropathic pain that have been shown to be helpful with hot flashes, helps with problems like sleep and anxiety and the mood changes, or even the libido changes that come along with this time period. And if I have somebody come in who says they have no symptoms other than vaginal dryness, well, then why take on the extra risk of an oral or a transdermal medication if really all you need is a topical one? So this is going to be such an evolving thing. The reason why it's so important to have a relationship with somebody is this is not a 15-minute conversation. Sure. This is a multiple visits over maybe a year and continuing to evaluate whether or not it's serving the goals you wanted it to serve for you. And it takes some time. We don't start you on an estrogen patch with an oral progesterone and literally the next day, all of your symptoms you've had for the last 10 years are gone. It should work that way. I apologize, but it takes time. And sometimes we have to adjust the dose, and we've got sort of good metrics in our head about when we need to abandon that plan, try a new plan, keep pushing. We aren't the ones taking these medications. We don't know what it feels like to be in your body. And we have to have that dynamic, that feedback from our patients that are actually taking these medicines. What does it feel like? And is it helping? And so that is the process. It really is a process to figure out what's going to work right for you.
If a woman is not eligible for hormone therapy for whatever reasons, family history, personal history, as Dr. Hay mentioned, there are other genres of medications that we can try for them. But there's also some alternative therapies, not medicine. One of them is, I learned recently about this new app that's out there. It's called Evia. And it is a sort of guided meditation app that helps women cope with and process their hot flash experience. And so we can include a link to that in the show notes. Yeah. But I started the process myself, just sort of seeing what it was like. And it seems very tailored to the individual. So that is a cool, like, non-medication option. The other one that comes up a lot is cognitive behavioral therapy, which is a therapy that focuses on changing unhelpful thoughts and behaviors and sort of promoting pattern improvement to help you cope with emotions. And that is a big emphasis in the menopause world of addressing and dealing with some of these changes. Not to say that we're dismissing your concern and that you just need to do therapy, but that therapy as an adjunct to all these other things can actually be really helpful in improving how you feel.
Well, because I think some of this is that it comes with baggage. It is a huge change in our lives. And for most of us, we are defined by those time periods where we either made babies or we were considered young. And to have this big change happen against our will comes with a lot of emotional baggage that maybe we didn't even know we were carrying, and maybe we don't want to carry anymore. And sometimes putting that luggage down is hard and we need help. And I think over and over again, cognitive behavioral therapy has been shown to be helpful with things that just doesn't feel like it should be, right? Chronic pain, insomnia, because it is perspective. And having that perspective that we're transitioning into this new phase in our life, you grieve the loss of where you were before. Maybe you thought you were going to have more kids. Maybe, you were hoping this wouldn't happen till a lot later. Maybe you don't have time for this right now. And so I think that's where the therapy component comes in. And maybe it's cognitive behavioral therapy and a patch.
Right.
But it's an important secondary aspect of dealing with what is a really big life change.
Let's say someone doesn't have a primary care provider. How would they get access to all these things that you've been talking about? And are things that you guys prescribe the same as bioidentical hormones?
I think first and foremost, everybody should have a primary care doctor or midwife that they see. But I think the beautiful thing about women advocating for themselves, that there have been a lot of new clinics that have popped up trying to address some of the issues that women are going through. And I do think in response to that, there have been many wellness clinics that have come about that offer women access to hormones in ways that are a little bit different than what we have access to at our clinics. My biggest concern with some of the alternatives out there is that this term bioidentical is essentially a marketing scheme. It is the exact same raw materials. One is created in a pharmaceutical company that does quality control, batch testing, tons of research to make sure that when you get a patch that is 0.625 milligrams of estrogen, that is exactly what you're getting every time without fail, and that we can depend on that. And the hard part with a lot of the bioidenticals that are coming from other avenues is that there isn't the same rigorous nature behind quality control, batch testing, things of that nature to guarantee that every time you get that compounded medication, that it is exactly what you think you're getting. I would say most of the time it is. Nobody wants to hurt anybody, but it just can't quite guarantee it the same. I think, too, there's been a huge push for different lab testing to help guide treatment. And the more information we have from the Menopause Society and the researchers out there is that a lot of that isn't necessary. There's definitely some testing that we would do to try and make sure we're not missing something that a lot of the wellness centers would do as well, but it doesn't really guide treatment. It's your clinical symptoms that do. And so I am usually pushing people towards, if they're going to go down the hormone route, because it does come with some risk, and you want to make sure you have a predictable combination of meds so that we don't end up with complications like what Megan was talking about as far as the lining of your uterus and making sure that we're not taking on added risk from a blood clot perspective. You want to be sure that you're always getting the same thing and that it is reliable. And for most of us, that means going through the rigorous process that sort of FDA-approved medications and pharmaceuticals comes with.
The other thing about lab testing is that often we're being asked, can you do labs to tell me if I'm perimenopausal? And that is a very difficult lab value to capture because the perimenopausal hormones are doing so much shifting and changing day to day.
Sure.
You might get different labs on different days. And so really, we can't necessarily tell you much by drawing your labs before you're menopausal, and it doesn't really guide our treatment. The thing that does guide our treatment is what you're telling us is bothering you the most.
Let's talk about long-term health. How does menopause affect things like bone and heart health?
We are actually finding more and more research about things that hormone replacement therapy can be helpful for. And we're finding that as you go through menopause and your estrogen falls off and gets lower, you're at higher risk for osteoporosis and diabetes. And we have found that people that are at highest risk for those things, if they start hormone replacement therapy within 10 years of their period stopping, even if they aren't having hot flashes or any of the other symptoms, that we can mitigate some of that risk of osteoporosis and diabetes if that's a strong family history for you.
There's some speculation about whether it helps improve outcomes with dementia, but there's a lot of clouded and unclear data on that at this point.
What screenings would you say are especially important at this stage of life for women?
If someone was coming to start hormone therapy with me, I would definitely do routine blood work, which would include a lipid panel, a complete comprehensive metabolic panel, which would tell me about their liver and their kidneys. I would probably check their thyroid, and I would want to know their diabetic status. So we would do all that lab work and kind of talk about their family history and their own personal history in regard to each of those things. And also, we would definitely want to make sure they were up to date on their pap smear if they still have a cervix, and up to date on mammogram. And then depending on their age, we always like to recommend a colonoscopy too. So those are the chief things I can think of.
I agree. Usually we start doing mammograms at age 40, colonoscopy or some sort of colon cancer screening is starting at age 45. Some of that would change based on your family history. We don't do pap smears until you're 21, and we continue those as long as you have a uterus until we've had normal ones leading up to the age of 65. So I would say for a lot of these people, they're continuing to have screening for things that would make us want to stop hormone replacement therapy. And we're constantly checking in far more often than we're doing pap smears or colonoscopies about whether or not it's time to trial a lower dose of the hormones and see if you still need it, or adjusting the dose if the symptoms don't seem like they're being controlled the way that you were hoping for, or if new symptoms come up. So I'd say while people are on these medicines, they're continuing to see us at least every 6 to 12 months. And in the very beginning, it's far more often than that. So we can make sure we're titrating medications because it can take 4 to 8 weeks to get the full effect of each dose of the estrogen, either by mouth if you're taking a pill or a patch. And so that takes some time to kind of evaluate your symptoms and if this is the right medication for you or not.
And the goal is always that you're using the lowest effective dose for the shortest amount of time. And so with that comes the need for follow-up to make sure that you're still benefiting, or if you can be altered in any way that would improve your ability to go off the medication sooner.
For women who feel like they've lost themselves a little bit during all these changes, what would you say to encourage them?
I think the most powerful thing I have found with anybody at any new stage in their life is just to feel like you're not alone. And knowing that it will get better, that you haven't lost your identity or what makes you important to society is huge. And I think that's what we were getting at earlier with cognitive behavioral therapy and therapy in and of itself. And then knowing that there are options, I think is huge. And I do hope that you can become your own advocate. There are so many books out there about what menopause looks like. If you've never had that conversation with your mom or your sisters or your aunts or your doctor, and if you don't have a doctor that you feel comfortable talking about this with, maybe that's a good sign that we got to reach out and find somebody that you can talk about these things with, because this is life. It's all a roller coaster, and you're going to have different phases, and having somebody there who can help support you as you go through them and stand by your side, I think is critical. And menopause is just one of so many of those life experiences.
And as the person going through it, we have to be willing to talk about it and discuss it openly. And the person on the receiving end needs to be willing to listen. I think just reassurance that you're not alone, and whatever you're learning, I'm interested in you telling me about too.
Well, and I think, too, recognizing that it feels really out of control to the person who's going through it. It really is kind of an identity crisis for a lot of us. Nobody wants to admit they're actually getting older. And this sort of slaps you in the face and wakes you up at night with it. And so it is a really big transition. And sometimes just feeling heard, you don't have to fix it. You don't have to make us better. We don't want to be thought of as a problem when we're having these things that has to get therapy because we can't be tolerated. It's a transition. Supporting somebody doesn't necessarily mean changing them or fixing them. Sometimes it just means hearing them. And, it is good news that it won't last forever, which is nice, but it could last for 20 years, which is also not fair.
If someone listening thinks they might be starting perimenopause but isn't sure, what should they do?
I think you can start by educating yourself. It always feels better to go and talk to one of those really smart providers out there and feel like you're on equal footing, that you know a lot about what your symptoms are, what you're worried about, so that you can feel like you can advocate for yourself. And like I said, there's fantastic books. I know that the Boone library here has a lot of them that you can check out. And then start having conversations. I know that a lot of gynecologists are well versed in this. Midwives are going to have a good idea about this. And unfortunately, a lot of us did not get great training in medical school about menopause and have had to do a lot of training outside of our formal education to learn about how to support patients as they go through this, whether or not it's medications or not. And so that's why kind of having some of your own information and being able to advocate for yourself is important, because who knows, maybe you're going to teach your provider. Maybe you're the person that helps them go on their own journey to take good care of their patients. This happens all the time, where I didn't realize I needed more education in something until somebody showed up by my door and was like, I'm miserable. You need to fix this. And I'm like, well, let me go figure it out. And so who knows? Maybe you'll change somebody's life by just asking questions.
I don't think you have to know if you're perimenopausal before you come talk to us. Like, we will help you figure that out.
Absolutely.
You know what's going on with your body. You describe it to us, and together we decide where you're at.
We are really comfortable as people who do obstetrics in not knowing things. Mm-hmm. And we are well aware that with this being a completely clinical diagnosis where no labs are needed to make the diagnosis, sometimes we're not right. And so that's why having a good relationship with whoever you're working with for prescribing medications or monitoring symptoms is critical, because sometimes the treatment of your symptoms is how we make the diagnosis. If you're having hot flashes and we think it's perimenopause, and then we give you estrogen and it gets better, then we go, look, we were right. But we are just really comfortable with that place of unknown and the fact that we don't always have all the details, but we are very sure something has to change and something needs to be treated. And we feel like hormone therapy is really safe. And sometimes it is diagnostic in how we make our diagnosis of perimenopause.
If someone wants to connect with either of you or learn more about women's health services at Boone County Hospital, what's the best way to do that?
We are always taking new patients over at the North Clinic and the South Clinic here at Boone County Family Medicine. The number for where I'm at and my colleagues at the North Clinic is 515-432-4444.
And for me, it's to call the Madrid Clinic to make an appointment. And the phone number there is 515-795-4300.
Megan, Dr. Hay, thank you so much for an honest, encouraging conversation.
Our pleasure. Thanks for having us.
Thank you so much.
And to our listeners, thank you for tuning into Healthy Talk. We'll be taking the month of December off for the holidays, but we'll be back in the new year with fresh topics, new conversations to help you live well in every season of life. You can find past episodes at boonehospital.com or wherever you listen to your podcasts. Until next time, stay informed, stay healthy, and keep the conversation going with Healthy Talk.